So I'm Marissa Young. I'm one of the faculty members in the Department of GYNOB. I practice at Grady and a member of the CTSA. And it is my great pleasure with Dr. Cherie Boulay, who couldn't be here today, to introduce Dr. Toby Goldsmith. So Dr. Goldsmith has been active in mental health care of women since 1995. From 1996 to 1999, she was the director of the Women's Mental Health Program at the University of Cincinnati and continued in a similar position at the University of Florida from 1999 to 2005. After that, she joined the Emory Women's Mental Health Program in 2006 and became the director in 2013. Dr. Goldsmith was raised and educated in New York, where she attended Cornell University. In 1991, Dr. Goldsmith received her medical degree, magna cum laude, from the School of Medicine and Biomedical Sciences at the State University of New York at Buffalo. At Vanderbilt University Medical Center, Dr. Goldsmith completed her residency in adult psychiatry, and upon her completing her service as chief resident from 1994 to 1995, she received the Mark Hollander Award for Outstanding Performance as a Psychiatry Resident. While Dr. Goldsmith has been involved in psychiatric research throughout her career, she is primarily invested in the clinical care of women, as well as educating medical students, residents, and others about psychiatric illness. She currently serves on the Georgia Maternal Mortality Review Committee, where she works with other health professionals to find means to improve the health of new mothers. While enjoying her role as a teacher and administrator, Dr. Goldsmith is most invested in her role as a caregiver to reproductive age women and their families. This passion has been recognized by her peers, as Dr. Goldsmith has been a recipient of the Top Doctor designation by Atlanta Magazine since 2017. And I'll let you go ahead. Thank you so much for being here today.
Thank you so very much. Yes, I'm extremely passionate about this, and unlike most of you in the audience, I am very much a clinician and not a researcher, but I'm going to give you as much information as I can so you all have a better idea of what we do here and how we can possibly work together going forward. That's me. And I do have no conflicts of interest. So let's talk about the problem. So Georgia is not alone. Rather, we are among 15 other states who received a failing grade from the Policy Center for Maternal Mental Health in 2023 for when they presented their inaugural report card. As you can see, there's quite a line of us in the South, and then as in the Upper West part of the country. While we are among 15 other states who got an F, as you can see, if you look at the yellow and the peach, a lot of our colleagues got a D or a D- as well. So what about us in Georgia? As I mentioned, we received an F. And there's multiple reasons why we have failed. There's a lack of screening that is going on, and there are a lack of requirements asking clinicians to screen, and therefore there's not enough data collection. There's a lack of insurance coverage. Our only passing mark was that we had postpartum Medicaid expansion. And birth givers now have access to Medicaid for a year after they deliver. And finally, there just are not enough people who do what I do. There are not enough perinatal mental health practitioners. So Peace for Moms was developed to help address that problem. We were developed as part of this national network of perinatal psychiatry access programs. So we are not unique. As of this month, earlier this month, there are 28 states plus DC who have up and running perinatal access programs. There are 3 states, New Jersey, Delaware, and New Mexico, who are aspiring programs. They're working on getting things going. 20 states remain without any access program whatsoever. Those states may utilize something set up by Postpartum Support International. So one of the things I'd like to let people know is, where does everything fit in that we're doing? Because we throw all these acronyms out, and different names and words and letters. So the Women's Mental Health Program has been in existence for well over 20 years. About a dozen years ago, I was asked to serve as the psychiatrist on the newly formed Maternal Mortality Review Committee, or MMRC. And it became very apparent from the first meeting that there was a need for greater psychiatric presence in the state. Several years later, due to the hard work of people in DPH, Healthy Mothers, Healthy Babies Coalition of Georgia, and Postpartum Support International Georgia, that funds were finally made available for the development of a new program, which is Peace for Moms. And we were asked to be part of that. And we have integrated Peace for Moms into the Women's Mental Health Program. So the Women's Mental Health Program has a very strong consultative service, but we also have an educational service. And we also have started, or last year we started, an ECHO program on reproductive mental health. We'll talk a little bit more about that in a moment. So the other thing that we do is we're very proud that we are the first and possibly the only program in the country which is integrated skills-based programming into what we do. So women from around the state now have the ability to participate in evidence-based programs that teach them how to cope with stressors that they may be facing on a daily basis. So the Women's Mental Health Clinic consists of two perinatal psychiatrists. It's myself and my colleague, Dr. Rebecca Wu. I said she's been with us since 2000. It's actually 2020. Should have noticed that. Between the two of us, we're able to see between 3 and 4 new patients a week, and somewhere between 30 and 50 follow-ups in a week, depending on the particular week. Today, I'm doing this in between all my patients, and typically on a Monday, I will see 13 patients, including 1 new patient. Who are our typical patients? So patients that we see in the Women's Mental Health Program are typically pregnant, possibly been pregnant within the last 6 months. We do preconception consultations. So someone who may be on medication wanting to know, can she continue doing what she's doing? We help people as well cope with recent pregnancies or infant loss. And we also work with a lot of people who are seeing a reproductive endocrinologist. Sometimes we'll do their consults before they're approved to get donor egg or donor sperm. Or like today, I'm seeing a woman, or I saw a woman today who is serving as a gestational carrier for somebody. And she wanted to know about her ability to take medication. So the women that we see in women's mental health are very similar to the women that we get consulted about in Peace for Moms. So why aren't they just being seen in our clinic? Well, it's because there's just not enough time in the day. So what we're trying to do is help overcome the various obstacles that perinatal people experience. And by being here as Peace for Moms, we help them cope with stigma, financially affordable, we're free. Someone may have difficulty with transportation. We can do an evaluation virtually. Racism is a big issue, and so people don't know about what is available, and they may not be told about what is appropriate for them. There's, in many communities within the state, stigma against mental health. There are a lack of mental health providers in general, and specifically a lack of providers who do what I do, which is reproductive mental health. And in general, there's also a difficulty for the providers on the outside who have limited knowledge about how to treat mental illness in general, and specifically during pregnancy and the postpartum. So the goal of our access program is to make it easier for patients and for clinicians to overcome these obstacles. So how do we help people? We are fast, we are free, we are flexible, we can change what we're doing in order to fit what you need to do. We are friendly and we are focused. We really want to work on perinatal mental health issues. Okay, so remember those 5 F's to keep in mind what Peace for Moms does to make life a little bit easier for you. One of the lovely things is that we really work over a spectrum of time. So we will work with you from preconception through the postpartum. Right now, we're working with individuals who are up to 1 year postpartum. So we will help you do everything from reviewing what an individual may be taking to talking about how a contraceptive may impact what's going on. We will help you come up with birth plans if necessary, postpartum plans, pregnancy plans, whatever is necessary for that individual. Once the individual is pregnant, we can talk to you about what meds they're on and how to treat any new symptoms that may be arising. We'll help with the diagnosis and the treatment planning, because unfortunately, sometimes the patients come in knowing they're unwell, but not knowing exactly what's wrong with them. We help with sleep and insomnia, which is a common problem within pregnancy, as you all know. And we have our skills-based program, which helps several people every month. Once the individual has delivered or their pregnancy is over, we can talk about meds during lactation. We can help delineate between postpartum psychosis and simply intrusive thinking. We'll help you with the treatment of such illnesses. We can help those individuals whose pregnancy ceased due to a miscarriage or to a stillbirth, and help with perinatal trauma and perinatal grief in general. And then again, we have our skills-based program, which also works with postpartum individuals. So let me just tell you how it goes from start to finish. So the first thing that has to happen is the clinician has to realize that they have a patient, they're pregnant, postpartum, preconception, and they don't know what to do with them. They've got some kind of psychiatric illness and they need some assistance. So hopefully someone remembers or someone tells them about Peace for Moms, and they call us, and that's our phone number. And they call us and someone will pick up pretty readily, usually within 3 or 4 rings. And what our community advisors will do is they will get some basic information from you and get a callback number. Please, if you do call us, give us your cell phone number, because it's a lot easier to get you quickly than to go through some long telephone issue. Peace for Moms psychiatrists will call you back typically within 30 minutes. I think it's more often closer to 10 minutes. If that won't work for you, we will set up a specific time. So we will guide you with screening or a diagnostic clarification. We will help you with medication and therapy choices. And we will provide as best possible resources that can help an individual and give you support in terms of referrals. So I will call and I will get all this information and give all this information to you as well. Oh, wait, there's more. Again, we can help you get your patient into the skills group. And if necessary, we can do a face-to-face consultation. Typically, those are virtual. And we will do those when there's just a big question mark about what's going on with this patient. Are they psychotic or are they anxious? Is this depression? Is this substance use? We will do this once and only once, and we will get you the results of our evaluation. And we try to typically get the patients in within a matter of days. Typically, they're seen within 2 weeks, but much less is our average. So where are our clinicians calling from? As you can imagine, given what the population of the state is like, most of our individuals are calling from the greater Atlanta area. And you can see that by those little dots there. And if you look at this, so this is based on information from earlier this month, based on consults we've received. And I just wanted to point out that these two little dots consist of 6 and 5 consults respectively. So even though there's only one spot there, that clinician has called us back repeatedly. And that's something that we find is that once someone gets over the barrier of calling us the first time, they're very likely to call us back and ask for help in the future. When are we seeing people? The majority of the calls that we get called about are from people who are currently postpartum or lactating. But as you can see, we see several people regularly who are pregnant, but we also see or answer questions about preconception and perinatal loss. And then there was a couple of others. Sometimes people have called us just because they know we're going to answer the phone and we're going to try to help them no matter what. But typically, we really want to work on this pregnancy, postpartum, preconception individual. So one of the other things that we do here, as I mentioned earlier, is our reproductive mental health echo. So this past Thursday, I did a presentation on the 10+ commandments of perinatal mental health. Next month, on the 15th of February, we will be having a discussion on grief and loss. And if you take a picture of this, it will come to the registration and you can get reminders and get the information about how you can join us. We do offer CME and CEUs. And we do one of these every month on the 3rd Thursday at noon. And we typically will do it between January and October. And one of the things that we reach out to individuals for is for cases that have something to do with one of our topics. And we will try to integrate that into our discussion with you. So what I've basically presented to you so far is who Peace for Moms is, how it fits into the women's mental health program, what kind of patients we've been seeing. But what I'd like to do now is just go over why we really need to exist. Why are we important? Why you should be calling us, why you should be telling your colleagues about us. So I'm going to go over just a variety of different numbers so we can understand how we fit in. So in this chart, what you will see is a comparison of different rates where we are looking at the number of deaths of a person who's delivered a live birth of, and it's a number of births per 100,000 live births. The first number is maternal mortality. And as you can see, Georgia, which is in the purple, and Georgia, which is in the purple, had a rate of 33.9 deaths per 100,000 live births, while the national rate was 23.5. The 23.5 is still horrible as you compare us to other industrialized countries. Then we talk about pregnancy-related deaths. These are deaths which have been determined by the Maternal Mortality Review Committee to have some direct relationship to the pregnancy. And those, let me just talk about some dates. Maternal mortality is basically from conception to 42 days postpartum. Pregnancy-related and associated deaths are from conception to 1 year after the delivery. So as you can see, in both cases, the rates for pregnancy-associated and related deaths in Georgia are greater than the national averages as well. And you just have to keep your mind open and clarify what is someone talking about when they're talking about different numbers, because these are thrown around the media a lot. So just another way of looking at things in terms of timing is to know that all the pregnancy-associated deaths and the pregnancy-related deaths, same timing, but any death that is pregnancy-related is also pregnancy-associated. Any maternal mortality death is both pregnancy-related and pregnancy-associated as it is considered. And this is based on World Health Organization criteria. So moving on, I wanted to show you again a way to look at it, that maternal mortality or death is up to 42 days postpartum, and pregnancy-related and associated deaths goes up to 1 year postpartum. Let's talk again about the causes of pregnancy-related deaths. So there's a direct correlation or causation between why the woman passed away and her pregnancy. And the number 2 cause is considered to be mental health conditions. And this is a combination of both substance-related deaths and suicides. If you look at the causes of pregnancy-associated deaths, you can see that large numbers of motor vehicle accidents. And all of these motor vehicle accident deaths were considered to be preventable. What's interesting is substance use disorders were considered to be a contributor to 21% of all those deaths related to motor vehicle accidents. And the leading contributing factors identified for pregnancy-associated deaths were violence and substance use disorders. So if someone is dying by homicide, it's very likely that drugs and or intimate partner violence were involved in some way or another. We see a lot of cases where they've screened for it, and then we find out later that the patient was not necessarily comfortable sharing what was going on in their relationship. So in terms of circumstances surrounding a death, so I'm looking here at pregnancy-associated, pregnancy-related, and an area we call pregnancy-associated, but unable to determine the relatedness. We see a fair number of those. But what I wanted to show you is one of the questions we are asked at our maternal mortality review committees is, did mental health conditions other than substance use disorder contribute to the death? And as you can see, that the majority of those, the answer is no. But in some cases, nearly 20% of the pregnancy-associated deaths, a mental health condition other than substance use did contribute. So postpartum depression could be an issue, some kind of anxiety disorder has been thought to be involved with this. And as you can see as well, the majority of deaths that had substance abuse as a contributor, the answer was no. In many cases, it's still yes, especially with the pregnancy-associated deaths. And remember that these are going to be a lot of those deaths that occur later in a pregnancy. which brings up a whole other issue in terms of when patients are actually being seen by a clinician. I wanted to show you some issues as well regarding race and ethnicity. In terms of pregnancy-associated deaths, as actually in every area here, non-Hispanic Black women are much more likely to die compared to their colleagues. And that's something that we see nationally. The rate is about 3 times as high among non-Hispanic Black women. It's also really high among Indigenous women. So in terms of leading causes of pregnancy-related deaths, if we look at the racial differences as well, here in Georgia, all of the mental health deaths with pregnancy relatedness were actually non-Hispanic white individuals. In every other area, African-American women occupied a large number of these. Maternal suicide, this is something that has intrigued me since serving on the MMRC. 62% of the individuals who are 62 of the deaths due to suicide occur at least 6 weeks after the delivery or end of the pregnancy. So between day 42 and 365. And this is a time where the individual patient is likely no longer seeing their obstetrician or gynecologist or midwife. So this is a time when they're basically floating around without assistance. And this is an area where we would like to engage more with family medicine, internal medicine, as well as just therapists in the community. So we can potentially change this. So I just want to go over some basic facts, and then what I'd love to do is answer any questions that you may have. The majority of the deaths that occur in Georgia, 87% of them occur in the postpartum period. Suicide was the manner of death for a majority of the deaths due to mental health conditions. The others were potentially accidental overdoses. Substance use disorder contributed to 47% of deaths due to mental health conditions. So if we can improve the issues around substance use, it's very possible we will lower the number of deaths due to suicide. And all of those deaths, either due to substance use or mental health conditions, were considered to be preventable deaths. One of the things that people need to keep in mind is even though the deaths due to maternal mental health conditions occurred only among white women in the state of Georgia, almost 40% of Black women in the state will experience maternal mental health conditions, whether it be postpartum depression, postpartum anxiety, or perinatal depression or anxiety, or psychosis. Black women are actually considered to be twice as likely as white women to experience these conditions, but only half as likely to receive treatment. And over 50% of postpartum depression cases in women of color go unreported. So the women just don't bring up what's going on with them. It's a huge issue in the country, in the state of Georgia. And I know that we in Peace for Moms are only making a small dent in it, but really believe that we can make more of a dent in it if and when we get more calls from individuals from around the state so we can help as many patients as we can. At this point, I would love to answer any and all questions that you all may have about what we do. and where we can possibly fit in with you and what you're doing. That was strange. I entered the waiting room again.
Yeah, there's a few, maybe it was your registration link. Well, thank you so much for that, Dr. Goldsmith. I'll ask the first question while other people are thinking of theirs. What types of, I wonder if you could just give a few examples of kind of where you feel like this partnership between clinicians and Peace for Moms has been the strongest. Some like kind of clinical scenarios that you feel like have been, like, what do you see as the kind of the target for these types of referrals that you get through Peace for Moms?
It's every and all clinicians who are treating any pregnant or postpartum individual, or preconception for that matter, who may be suffering from any kind of perinatal psychiatric condition. But at the same point, I think sometimes the best work that we're doing is when we're keeping the woman from being sent to an emergency room because she's scared her OB or she's scared her midwife because she said she's having thoughts about dropping the baby over the balcony or something similar. And we are able to work with that clinician to understand the difference between an intrusive thought and a thought filled with intention. So I think those are very important places. It's a matter of helping people be more confident as well about prescribing medication. It's understanding that there's more than sertraline out there, and that with a little tweak here and there, the difference between 20 and 40 of fluoxetine can be huge for a patient and their level of functioning. So our being here just to help you and presenting as much research as we can, I think is very helpful for people. We'd also love to, you're asking where we can make a difference. Emergency rooms. We would love to see more screening in emergency rooms, because a lot of individuals who show up with somatic complaints are actually suffering from an underlying psychiatric condition. And if we were to screen every woman who's been pregnant within the last year, I think we'd be able to treat a lot of individuals and possibly definitely improve our morbidity and mortality in this state.
I have a question.
Go ahead.
Thank you so much for this presentation. And I acknowledge I'm not a clinician, but I often wonder about screening and a comment you made about kind of people are often not reporting their mental health conditions. And I wonder if you have advice or thoughts about how screening could be done better. I can imagine, especially when you're a new mom, being really afraid to disclose that you're having these thoughts at all, even on an anonymous form or a not so anonymous form. And so I've often wondered about the quality of our screening forms and if there's different ways to deliver them, even not using clinicians or someone else to do the screening.
I personally feel if you normalize the screening, that it happens at every visit potentially, people will be much more likely to start filling it out truthfully. In addition, if clinicians make sure that things are not ignored, because I have heard patients say to me, yeah, I filled out their form and I clicked off whatever, got a score of 16 and no one said anything to me. I just filled out a form. Why are they going to even bother filling it out? So we have to pay attention to the results. And the clinicians need help, whether they're a pediatrician who's seeing the mother and being asked to screen as per the American Academy of Pediatrics, or an obstetrician or a midwife. All of those individuals need to screen and then know what to do with the information in some way. Whether it is, oh, look, I know a psychiatrist who could see you. I know a therapist who can see you. I know about this support group. And a lot of times you all don't know, and that's not your fault. But that's what we're here for, is to help you find those answers for your patients. I hope that helps, but I really just think if we screen regularly and say to patients, we just want to, let me give an example. If an individual were given a screening test, say at 8 weeks pregnant, it's very likely that we will be able to predict whether or not she actually came into this pregnancy depressed or anxious or whatever we're doing it for. If we do it approximately 12 weeks later, while she's in the second trimester, we can see if depression has developed. And we can also do that again during the third trimester. If everything is low and there doesn't appear to be any abnormalities, great. But then once she becomes pregnant, postpartum, we can determine whether or not she has developed postpartum depression, or is this an exacerbation of this pre-existing condition that we had. So we just need to do this regularly. And we also need to get the state to pay for the screening. That would help too.
Yes, thank you. And I definitely agree. Getting the state to pay for screenings or even therapy is an important goal.
Oh, that's a whole other issue. But I agree with that one. We need therapy paid for it, which is why we do our groups as well, as to teach people things and then try to help find them individual therapists if we can.
Any other questions for Dr. Goldsmith?
Hi, I have a question. That's okay. In your experience, do you know where people go looking for information when they're having a mental health situation, like at home? Like you gave the example of the intrusive thought of throwing the baby over the balcony. What do you know where people go to? Do they look online? Do they ask relatives? What community?
I think it's Dr. Google primarily, where people are just going in and trying to find things out, and hopefully they're going to a good website and getting good information. Patients occasionally will go to a clinician and ask for help, but a lot of times the clinicians don't know. And depending on what community that you are living in can make a huge difference. There's a lot more available to clinicians who are here in the greater Atlanta area. But for somebody who's down in Valdosta, there might be many more challenges in terms of finding what's necessary.
Yeah, and how intense do you think the experience needs to get for a birthing parent to seek help? You know, like
I think it depends on the individual, very much so. Have they experienced something like this before? Have they witnessed this in someone else? Is there someone in their network, in their home, who understands what may be happening at this point and says, hey, listen, you're not yourself? I think it really depends. And unfortunately, there are people who will never ask for help and get to the point where bad things happen.
Yeah, really. The reason why I ask is because I've worked with a project with Alexis Dana Moore. I don't know if some of you may know her, on building a web online tool that it's called Mama Love. It's to support like birthing parents who have symptoms, either physical but also mental health. And you know, just seeing the research that you brought, I'm amazed, and I can't wait to tell her about it, to include also Peace for Moms in that list, because it sounds like you do a lot of follow-up and support, which is amazing. And a lot of the resources, sometimes it's a nice website telling you a lot of information, but the action item seems very far away from someone who, you know, is not familiar with the whole medical system. So yeah, I'm really excited, and thanks for this talk.
You know, we are constantly trying to build up resources that are available for people. So we'll find out about a new organization and we keep track of what that information is. Now, the one important thing about Peace for Moms that we need individuals to keep in mind is we are a clinician-facing organization. If a patient calls, our community advisors tell that patient, we need your clinician to call us. Here's the number, please ask them to call us and we will help as much as possible. If you were to go to our website, you would find I'd say towards the back, that's how I'm old, that's how I view a website. But we have tools for individuals. And among those are things like letters that a therapist can send to a clinician, a prescribing clinician, or a patient can send to a prescribing clinician and say, hey, I think I might have something wrong. And Jill Mast, who is the nurse for Peace for Moms, just put up in the chat what our website is, but it's peace, the number 4, momsga.org. But if you also just Google Peace for Moms Georgia, you'll find us. But we have lots of tools that are available to help people communicate. But remember, we are clinician facing.
Got it. That's a good nitpick to remember. Thanks.
Thank you. You know, looking at who's here, there are a lot of people who are part of what I do. As I said, Dr. Jill Mast is here, who's our nurse, Whitney Adams, who is our therapist and runs our skills group. Courtney Daniels, who's from DPH, is here. I think I saw our program manager, director, a few minutes ago. Erica Washington was here. So it's a big group of us who do what we do.
Well, thank you so much for that. That was a really wonderful presentation and amazing work that you all are doing.